All right, let's learn about cardioversion, both synchronized and unsynchronized. First thing to talk about is pad placement. The usual sternum apex lateral position is just fine. You can also do anterior posterior. Make sure you get really good skin contact. You may need to remove some hair, whether it be with shaving with one of the disposable razors or better yet, some powered clippers. Or you may need to put a pad on and press it real tight and then rip it off and do an emergency field waxing. But good skin contact does matter. Don't place pads over implanted pacer defibrillators or other implanted devices. Try not to place the pad over any medication patches. Get the patch off. Wipe the skin clean if you can. And stay out of puddles of water. It's okay to shock somebody on snow or ice, just not in a puddle of water. When would you use cardioversion? Well, as soon as you find an unstable patient. Before you mess around with IVs, O2, airway, PEEP, bronchodilators, meds, anything else, you don't even need the ECG limb leads attached. So as soon as you identify that patient is unstable, which if you walk in on them and they are unstable, move right to cardioversion. When would you use sync versus when would you use unsync? Well, some ECG rhythms require synchronized cardioversion for patient safety, so you don't turn that rhythm into VFib. Those are narrow QRS tachycardias, whether they're regular or not. So narrow regular and narrow irregular tachycardias are going to get synchronized. Also, wide regular tachycardias are going to be synchronized. So that leaves the only unsynchronized cardioversion for that wide irregular tachycardia. Or if you have VFib or pulseless VTach, of course, you would go ahead and do the defibrillation there. So remember, unsynchronized cardioversion is defibrillation. There are times you would defibrillate someone with a pulse. Those are the unstable, wide, irregular tachycardias. Unsync, we call it defib, but technically unsynchronized cardioversion is delivered immediately when you push the shock button. You push shock, shock is delivered. Because it doesn't matter where in the ECG cycle the shock hits, whereas on synchronized, it does. We'll talk about that in a second. Energy levels for unsync cardioversion, 120 to 200 joules. You get to pick the energy level. The range is there as part of ACLS guidelines. They're not protocols, they are guidelines. And so you get to pick between, and usually what happens in the field is that your medical director and administrators have already picked, and your machine automatically will pick the correct shock level. But just so you know, 120 to 200 is what we're looking for unsync. Now, on synchronized, why would we even mess with this? What's it a big deal? This is because there's the R on T phenomena, which is theoretically and proven, when you deliver a shock wave on the T wave, you can cause VFib. So we want the shock wave to hit on the R wave, not on the T wave. So the R wave of the shock could come on a T wave, and it's impossible for you to physically time it correctly, so you need the machine to do that for you. So we're trying to time that shock wave to hit the R waves. And that, if you want to know more about that, you can review the refractory and relatively refractory and absolutely refractory periods. Sync is not very frequently done. The machine makes you intentionally push the sync button, and then once you deliver a shock, it knocks the sync off. Sync is not the most common way that we do things. When you first push the sync button, make sure that the machine is flagging the R wave. So when you're in sync mode, you should be seeing small indicators, usually at the top of the screen, that are over the R wave. Make sure they're not flagging the T wave. Patients with really tall T waves, either that are having ischemia, injury, infarct, or have a hyperkalemia, can have very tall T waves. An example there where the T waves are taller than the QRS. And so the machine could be fooled and either count the T waves as the actual QRS, in which case it would absolutely be wrong in terms of where the shock is, or sometimes the machine will count the QRS and the T wave and give you a twice as fast rate as what is actually there. It looks at that T wave as kind of a pseudo QRS. So be aware of that, not just when you're synchronizing, be aware of that in general. If you run across a patient with a crazy fast heart rate and you look down and there's tall, extremely tall T waves, then change leads. Get to a different lead and you'll get a different view. And if that doesn't work, then turn down the QRS size, and that will usually help you. I've seen this in the field, and that's the way we solved it, was by switching to a different lead, and then the machine was correctly counting the heart rate. So if you're going to do synchronized cardioversion, you really want to make sure that it's not counting the T wave and flagging the T wave and going to put the shock on the T wave. That's exactly why we're doing synchronized. All right, so last thing, the shock is delivered when the machine decides to, as long as you give it permission. So you push and hold the shock button. That gives the machine permission to shock when it decides it's safe. When it sees the R wave, it delivers the shock. You're giving the machine permission to do that. So a really good practice would be to push and hold that shock button until you see the shock delivered. You see the patient react, and you see the shock delivered on the EKG screen, always. Not just when you're doing synchronized, but always. So push and hold shock buttons from the time you're in EMT class on would be a real good practice. You've got to be sure you do it when you're doing synchronized cardioversion. So real quick overview of cardioversion, both sync and unsync, why we need to sync, how we sync, and then we talk about specific dysrhythmias and how we treat them. We get into the specifics on energy selection and this and that. But this is a general overview of cardioversion.